Okay, let's wait one more minute to give everybody the opportunity to be with us when we start.
I should explain, my beard is not usually this long, but when the lockdown started. So I think when phase 3 comes, my beard will be different after that.
Yeah.
We will do a data at breakfast webinar on that topic. Yeah.
No, that's a good idea. How many men grew beards during the lockdown?
Okay, our numbers are still increasing. Let's wait another minute or so that everybody joined us.
Yeah, 143.
Okay, now I think slowly the curve is flattening.
Even the chats have started.
Wonderful.
Good morning, everyone. Morning. Okay.
Okay, I think the numbers are stabilizing, and if people want to join us in a few minutes, they're still able to do so. Okay, so good morning. Let's start. Good morning, everybody. Welcome to this edition of Data at Breakfast. And this morning we have a very topical topic, yeah. And this is the debate about smoking and COVID-19. Yeah, and we are very happy to have with us Professor Mosa Moshabela, who is the Dean and Head of School in the School of Nursing and Public Health at University of KwaZulu-Natal. Many of you might know him because he started so he's a warrior because he started the COVID-19 war room at the University of KwaZulu-Natal, and he's also a member of the Department of Health provincial war room for COVID-19. Yeah? As if he's not busy enough with that, he's also an adjunct faculty and a former Wellcome Trust Research Fellow at the Africa Health Research Institute in South Africa. Yeah? By profession, he's a chief medical specialist, and he's trained as of course, a medical practitioner, but also in family medicine and in demography and health. Yeah, and he did his PhD in the field of public health. His research is focused on HIV, TB, and drug-resistant tuberculosis in recent years, and many other interesting topics in that area. Recently, he was also nominated to the Academy of Sciences of South Africa as a member of their Standing Committee on Health. So he's a real expert in the topic. Next to Professor Moshabela, we have Ronel Seepaul. She's a statistician at the Human Science Research Council. Her research is focused around biostatistics, so that it really fits with our data at breakfast team, survey methodology, health risk behavior, and health promotion research. Yeah, she has worked on several national public health and risk behavior surveys, including, which is relevant for today, the Global Youth Tobacco Survey among high school learners across the country, and the South African National Health and Nutrition Examination Survey as well. Yeah, she has been previously involved in examining tobacco use behavior and trends among both adults and young people. So Ronald, welcome to our Data at Breakfast. Our third panelist is Yusuf Saloji. I hope I pronounced his surname correctly. Yeah. He retired in 2017, but I think he's still very active. He was the executive director of the National Council Against Smoking, which was South Africa's first tobacco control civil society organization. Yeah, but he started his career as a scientific researcher. He published a lot, and eventually he became an advocate, policy advisor, and educator who played a role in ensuring comprehensive tobacco control legislation in the country. Yeah? And some of the things that he did became a model for the rest of the African continent. Yeah? In the late 90s, he took an additional responsibility by making contributions to the development of the World Health Organization Framework Convention on Tobacco Control. So he's been a long time advocate of the issues that we're discussing this morning. And he has served on the boards of many international organizations. He was also the chair of a World Conference on Tobacco and Health in 2006. He also received a prestigious award, the American Cancer Society Guta Terry Award for outstanding individual leadership. So Yusuf, welcome to you as well. Yeah? Before I ask the first speaker to start, I quickly want to review the rules of the webinar. Yeah? All the participants, and now we have just under 200, have the opportunity to ask questions using the question and answer facility of Zoom. If you look at the bottom bar, there is a Q&A. There's already a red number. That's the number of questions that have already been posed. There you will be able to pose your questions. Some of you participants emailed me yesterday questions, so please put them back in the question and answer facility at the bottom of the screen. Yeah? And the panelists will browse the questions and answer them in due course. I think the first panelist who wants to speak is Professor Moshabela. So Mosa, please, I think you want to share also some slides with us, so take control of our screen.
Thank you so much, Francisco, for the invitation. And I really appreciate the opportunity to speak. And I also want to thank the other panelists for joining. And greetings to all participants and from local and far and wide. I'm aware that there's people from other provinces and other universities who are here. So we just wanted to take this opportunity, given the fact that we are functioning in very uncertain times. And whenever we don't have enough information, it leaves room for confusion. And we then tend to fill those gaps with a lot of misinformation, and whatever is thrown at us, we tend to be eager to digest it as information. I'm just going to quickly go through some slides to set the scene and show some of what we've been reviewing in terms of trying to help us come to some sort of sensible conclusions about these issues around smoking and COVID-19. And then my panelists will also come in and discuss other aspects of this issue. As you can understand, it's a very complex issue with many layers of complexity that we're going to try and unpack a little bit. But first and foremost, we are hoping that we can deal with the science and put it aside. If you still feel that there are gaps, please highlight them for us so that as we move forward, we know what other future research recommendations we need to make. So just as a way of background, for most of you will probably know this, but for those of you who are not aware, the issue starts with the regulations about a couple of weeks ago that when we're moving from the hard lockdown to what now became a level 5 lockdown, alert level 5 to alert level 4. And what then happened was that people were informed that by the president that we are going to lift the ban on cigarette sales. But when the regulations were put up for public comment and then everything was returned and finalized, the Minister of Cooperative Governance and Traditional Affairs, who basically has the duty to oversee, I suppose, the Disaster Management Act work and activities, basically said that we will prohibit cigarette sales going forward, even in alert level 4. Now, I just want to highlight one thing, that I've looked at the regulations, and I'm not a legal person. I'm a clinician, but what they say is this: they talk about the duty to address, prevent, and combat the spread of COVID-19. Now, of course, this can be left to interpretation and we can come back to it, because I found it interesting when I reviewed the arguments that were being made by the two associations that were challenging the government. One focused specifically on cigarette sales, or maybe smoking, I'm not sure, does not slow spread, which speaks to what then they will call the mandate of the scope of the regulations, which then also the other association, BAT, basically accused government of ultra vire treating the regulations. They felt that the regulations were ultra vire the act, so beyond the scope of the work, and further that they were unreasonable. We can talk about that. As I said, that's not my area. But my interest was in the fact that there's a number of issues there that we can come back to. One, of course, it's a procedural issue that we can we can discuss later. The other one is an issue that has to do with whether government has the authority to do this or not, and who does it, but also the issue of whether this is reasonable or not. Yeah, there are other issues like communication and what we call flip-flopping, changing your mind, which apparently a wise man can do, or a woman, but it might be an issue for other people because we want consistency. Anyway, the issue that I want to speak to right now is the issue of the evidence around this. And I thought of a duty that we have. My interest is in COVID-19. My interest is in making sure that we are mounting the most optimum response in this country in order to contain COVID-19. So whenever we have questions or issues raised in the public that are challenging the public, that are challenging the government position, which everyone has a right to, we also have a right to, but are also challenging the public sentiment and public perception and public opinion, it becomes a problem for me. Because for me, I work from a public health perspective, and we are interested in the behavior of people. Behavior of people depend a lot on what they know, their perceptions, what they learn. And at the moment, because there's a lot of gaps, this is a condition that is relatively new. We've only known it for about 4 months, and we are navigating uncharted waters. So people are hungry for information, and they are absorbing a lot of information from the media. We just need to make sure that what we put out responsibly, so that we are all channeling in the right direction to serve the interest of the people. But of course, there are many interests, and we can come back to that. But this is my interest. My interest is in containing the spread and the impact of COVID-19. So, because of the regulations, I just want to focus on these two questions. Does it slow the spread of disease as a litmus test? And does it ease the pressure on the health system? The regulations refer mostly to spreading the disease, but indirectly to the capacity of the health system, including human resources and various other things. We can talk about that as we discuss. But here's the thing, that there is so much interconnectedness between SARS-CoV-2, the virus that causes COVID-19, and all the behaviors of people and the different demographics of people. And all of these things then combined, individually and combined, they determine whether people are going to have severe COVID-19, mild to moderate, and asymptomatic kind of disease. Even the people that are asymptomatic, we know they can spread the disease. Now, one of the things that we have learned with COVID-19 is that this is not an issue just about you, the person who is at risk or who is having the disease. It's also a public health issue, because what you do or don't do affects a whole lot of other people. So yes, you may have your right But then it raises the question of what your responsibility is. If we just think purely from the basis of what your right is to your freedom, but if your freedom infringes all on the rights of others, then that becomes an issue, and we have to think about it. So because there is this overlap with the behaviors of society, the personal spaces, the personal characteristics, which generally is, we've always known in public health that is there, but for COVID-19, it just stands out so much more, which makes it even more difficult. Now, we all know by now how the disease is spread. I hope we do. But in general, it's spread through droplets, and it is inhaled and it gets into the lungs. The issue is, it's also spread through what we call fomites. It touches surfaces of various things, cell phones, tables, glasses, utensils, various things that we tend to exchange. Now, because we know this, we have a rationale, and we work with an assumption that we must be careful when we exchange things, that those things could transmit SARS-CoV-2. Therefore, we have a responsibility, one, to make sure that we don't transmit the virus to other people by washing our hands, but also to make sure that we don't necessarily touch our faces after we have exchanged fomites between us. This is important, and because, as you will see, it's an argument that is being made by the World Health Organization, that the acts of smoking increase the risk of infection, this touching issue. And this is an issue that, as I recall, the Minister of COCTA referred to, and it is here stated by the WHO. But someone may ask, do we have the evidence to support this? And what I would ask is, if we know the transmission, the viral transmission dynamics, do we need to have the evidence? Do we need to prove all of this before we adopt protective, responsible behaviors? So it's something that we need to think about, because when we don't have enough evidence for everything, then people are going to exploit those gaps to basically twist the argument. I mean, this is what we do, and maybe in law it's okay, but when it comes to making sure that we are protecting the public, we need to also balance the risk and the danger of doing that. It can be quite irresponsible. It can constitute misinformation when we do that. They also emphasize the fact that smokers already have lung disease and reduced lung function. Now, you will see also that there's a general acceptance that tobacco is harmful, smoking is harmful, and we have known this before. But I'm interested in it currently in relation to COVID-19. And because we've proven it for other things in terms of its harms, but we have not proven the evidence because we haven't had the time to do that in relation to COVID-19. There will be gaps, but we accept that these dangers exist. So we know that smokers are going to upregulate the ACE2 receptors. And I'll show you the receptors just now, which means that they're going to have a whole lot more of them. Now, these receptors are an entry point for COVID-19. We may not have proved that people who are smokers or heavy smokers are going to have more of COVID-19. And I will show you that as well, because we don't have that evidence. But we can use deductive logic from this overexpression that they may be at a higher risk. Maybe, I'm not saying that they are, given this hypothesis that comes from here. And you will see that SARS-CoV-2 will attach to the ACE2 receptors. Now imagine if you've got a whole lot of viruses waiting to come in, and you've got a whole lot of ACE2 receptors that are expressed. We are working with a hypothesis that overexpression will increase the risk of transmission. It's a hypothesis. It's not something that has been proven yet. Now, interestingly, there's a recent paper that has been released from France, and it talks about the potential of nicotine playing a protective role from COVID. And the argument here is that because nicotine also interacts with ACE2 receptors, they are deducing that it binds to ACE2 receptors and therefore prevent the virus from binding. And how did they get to this conclusion? They did what we call a cross-sectional survey. And Ronel, we're going to ask you to explain what a cross-sectional survey is in a moment. But they basically look at people who are admitted to hospital and those who are coming to outpatient in the hospital, and took their history of smoking and basically said that, well, among those inpatient, there's 4.4%, and among those who are outpatient, there's 5.3%. And if you compare that with the general population, where smoking is as high as 25.4%, then current smokers have a much lower probability of developing symptomatic or severe. This paper has been thrown around by people who are arguing that it's a better idea to ban cigarette sales and there's nothing wrong with smoking. Now, if you're going to throw around this kind of evidence, you're triggering us to also throw around the evidence that challenges this. But if you are going to accept that the evidence is conclusive in terms of the risks that it brings around COVID-19, then there's no controversy. But this paper raises controversy. They go further, these guys. They basically have used this paper to argue for a clinical trial, which is still waiting approval. It's not been approved yet, to try using nicotine patches, not smoking, nicotine patches, in order to see whether it could play a protective role. And just that alone is important, because they're not necessarily going to do a trial of smoking tobacco. They're going to try and use nicotine patches. But I've put a link there of a critique of this paper that I think is interesting. And if you are really interested in this paper, look at it, because it highlights the flaws of this paper. But there's another paper that contradicts this, guys, that basically says that nicotine increases the vulnerability of COVID-19 patients, the cardiopulmonary vulnerability, and because it primes ACE2 receptors instead of blocking. Now, this is what happens when there's not enough evidence. People can pretty much start to make assertions, but I have to say that having reviewed this paper, which basically reviews literature to look at it, even though it's a perspective, but the method that they follow is stronger than the method that is followed by the people who did the cross-sectional survey. I am also willing to work with this hypothesis. If we dispute this hypothesis, it's fine. But whenever evidence is not conclusive, we need to err on the side of caution. We can't get reckless because there's one paper that challenges. That's not how science works. We basically work with the weight of evidence. There will be a lot of papers, and currently the weight of evidence does not necessarily favor this thing about nicotine being protected. But there is evidence that goes against it. For the people that may not see this evidence, because in social media circles and other circles, people will only see the paper that was published in The Economist or wherever else it was published in terms of nicotine, the role of nicotine. So Ronel, I would like you to take a moment to explain the difference between a cross-sectional survey and a cohort study. And the reason I'm asking for this is that from the work that we have done, we know that there is no evidence to suggest that smokers are much more likely to be infected with COVID-19 than non-smokers. We don't have that evidence. And to prove that, there's a specific design that one needs to be able to use, and it's called a cohort study, which takes a long time. But I'm going to ask Ronel to speak to this issue of study designs and what they're able to tell us. You need to unmute.
'Cause Sorry about that. A cross-sectional survey is usually done at one moment in time. So the study on the nicotine patches being protective was done at a particular point in time, and it looked at the smokers versus the general population at that point. Whereas a cohort study is a longitudinal study. It takes people and enrolls them into a study at baseline, and then it follows them up over time to check the changes that have happened over time. For example, the development of a disease over time according to the exposed and non-exposed populations.
Thank you. We will then be able to say, if once we've done a cohort study, whether a certain exposure is a risk factor or not. But we cannot say that with a cross-sectional study. And of course, in epidemiology, we rank this evidence. And cross-sectional studies are lower in terms of strength of evidence than case control studies and lower than cohort studies. And cohort studies are lower than clinical trials, which are lower than systematic reviews and meta-analysis. And we'll talk about that just now. But if anyone, for those who are scientists and students who's interested in actually looking further at this, this is an area that one might actually pursue. So just to say also that the Center for Tobacco Control and Research in San Francisco points out these risk factors for COVID-19. People above 65, chronic lung disease, heart conditions, diabetics and hypertension, and immunocompromised. We don't have strong evidence around immunocompromised, but I'll show you that we've got enough evidence to support these things. Why is it that we are worried about severity of disease, or whether people have asymptomatic or mild disease or severe disease? The reason we are worried about it in terms of combating COVID-19 and the spread of COVID-19 is that a lot of the people, this category of severe disease will expand if a lot of people who are susceptible to severe disease are going to suffer from severe disease. And when they do, they're going to demand a lot of extensive healthcare. This is also where a lot of infections to healthcare workers also happen, and infections to other patients happen in hospitals and healthcare settings, as we have seen in this country. Now, also there will be demand for intensive care in hospitals, which is very expensive as well and is very limited. And also there's then also demand for ventilation. This is the problem with it. But there are these three studies that I've put here that basically support all of those risk factors through systematic review and meta-analysis, except for the immunocompromised. And the immunocompromised, we've always said that we don't really have enough evidence about that at the moment. And in many respects, it's going to be for South Africa to be able to demonstrate that. Ronel, I'm going to ask you again to explain what a systematic review and meta-analysis are.
So a systematic review looks at quite a few studies and sort of synthesizes the evidence, while a meta-analysis does the same thing, but it uses statistical methods to synthesize all of the information, and it looks at the different treatment effects. It accounts for the variability between those studies and their study methods, and then it puts them into a sort of model to come up with an absolute or net treatment effect that summarizes all of the findings of the different studies.
Yeah. So to put it simply, I think is to say that these studies, they are the highest level of evidence that we have, and all of them converge around the same argument. One is that smoking contributes immensely to progression to severe disease. That is very clear. And in as much as there may be inconsistencies in terms of data around hospitalization and so forth. Some of them are focusing on that, some are not. But some of them are focusing on mortality, some are not. But all of them converge around increasing severity, progression, disease. And that's important. And that is a conclusion that we can accept. They raise a lot of measurement concerns. For example, how smoking history is collected, because there tends to be underreporting of smoking, especially in health facilities, and how the different studies have measured it. But I just want to also talk about mortality specifically. And there's this observational study that looks at a huge data set from Asia, Europe, different countries, and is published in New England Journal of Medicine, and basically demonstrates that people who are currently smoking have a 79% increased odds of mortality. Now, this is very strong and compelling evidence, and it's consistent. And you can see that it's consistent with other things, including age, it's consistent with heart disease, it's consistent with chronic obstructive pulmonary disease, and so forth. So it will help if people understand this evidence and accept it so that we don't have to keep debating it. But let me just make reference to this conclusions from the meta-analysis. They show you the study that they've synthesized, they show you the evidence, they show you the risk that there's more than twice the risk of progression to severe disease among smokers. And they specifically say that physicians and public health professionals should collect data on smoking as part of clinical management and add smoking cessation to the list of practices to blunt the COVID-19 pandemic. There's a number of these conclusions in this conclusion around smoking cessation in the various papers. So I'm going to stop there. I just want to flag that we've identified a number of questions that have been submitted to us already. We are going to go through them. And I'm going to let Ronel speak next so that we can take these discussions together as we move forward. Ronel, you can share your screen.
Sure. Good morning, everybody. The Human Sciences Research Council conducted a series of, well, 2 so far, social biobehavioral panel surveys. And I'm going to present data on tobacco use and cigarette buying from these 2 surveys, Wave 1 and Wave 2, which were conducted over the past 6 weeks. The first was conducted from the 27th of March to the 2nd of April and consisted of over 50,000 people, while the second we call the lockdown survey, and it was conducted from the 8th to 24th of April, which was right in the middle of the lockdown, and it had just under 20,000 people. The surveys were conducted online as well as telephonically, and data from these surveys is benchmarked using the general population demographics from Statistics South Africa to allow generalizability of the findings. From Wave 1 in the survey, and this was done during the first week of lockdown, we looked at participants who smoke, and we found that 14.8% of participants reported being current tobacco smokers, and 22% lived in a home with someone who smoked. The latter was an indication of passive or secondhand smoke exposure. The provinces with the highest smoking prevalence were the Western Cape, where 20% of people smoked. The provinces with the highest prevalence of people who lived in a house with someone who smoked was the Western Cape, Northern Cape, and Free State. Current smoking was significantly higher in male than female participants. It was highest among the age group 30 to 39 years old, the people from the colored population group, unemployed participants, and those who were employed informally or part-time. Current smoking was higher in people who lived in a room or house in a backyard, what we call backyard dwellings, than those who lived in a standalone house or a flat. Living with someone who smoked was highest among the youngest age group, which was 18 to 29-year-olds, people from the colored population group, students, participants who were employed informally or part-time, and those who lived in informal dwellings or a house or room in a backyard. We asked the smokers about their structural and living conditions. Over half of current smokers reported that they live in a household with school-going children. And over a third of current smokers reported that if self-isolation became necessary, their homes did not have sufficient space to separate the family members, such as the children or the elderly, from the rest of the family. And these represent a significant proportion of people and households for whom COVID-19 infection would be difficult to contain should one of them become infected. We then looked at cigarette buying behavior from the second survey, and we found that the most adhered to the lockdown regulations. The majority of smokers, that's 88% of smokers, were not able to buy cigarettes during the lockdown. A small percentage, that's 11.8%, reported that they were able to buy cigarettes during the lockdown. Almost a quarter of smokers in informal settlements and 16% of those in townships were able to buy cigarettes, which was significantly higher than those in the city, suburb, and farm settlements. Cigarettes were more accessible than alcohol during the lockdown. We see that only 2.5% were able to buy alcohol during this time. Cigarette buying prevalence was significantly higher among the youngest smokers, aged 18 to 24 and 25 to 59, than those who were aged 60 and above. Significantly more males than females were able to buy cigarettes. Cigarette buying was highest among people from the colored population, where 22% of them bought cigarettes, and lowest among the white population. Significantly more smokers whose highest level of education was secondary school were able to buy cigarettes than those who had a tertiary education. The Western Cape and the Northern Cape were the provinces with the highest prevalence of cigarette buying. Cigarette buying was highest in smokers who had lower confidence in protecting themselves and their families from COVID infection. We had a statement that said, "I am confident that I am able to protect my family from becoming infected." And participants smokers who disagreed with this statement quite strongly had a higher prevalence of cigarette buying. Cigarette buying went together with alcohol use. It was more prevalent among those who were able to buy alcohol than those who were not able to buy alcohol, where 71% of those who were able to buy alcohol during the lockdown also bought cigarettes. Cigarette buying was also more prevalent among those who were able to drink alcohol with their friends than those who were not. In terms of social distancing behaviors among the population that was able to buy cigarettes, the percentage of participants who came into close contact, that's by shaking hands, hugging, or kissing with someone outside of their home, was significantly higher for those who were able to buy cigarettes during lockdown, 26% versus those who were not, 9%. Over 40% of those who were able to buy cigarettes came into close contact, that's within a 2-meter distance, with over 10 people when away from their homes, compared to 26% of smokers who did not buy cigarettes during lockdown. Therefore, during lockdown, cigarette buyers were in close physical contact with people outside their homes more often than the non-buyers, which suggests that they were not practicing appropriate social distancing behaviors. And as we know, social distancing is one of the most important behaviors to reduce the spread of COVID. Furthermore, sharing tobacco products like cigarettes or hookah pipes can also increase the risk of COVID-19 transmission in communal and social settings. And we know that sharing cigarettes or sharing puffs is more common in lower socioeconomic backgrounds. We did some calculations on the estimated number of smokers and the potential need for ICU admission or for ventilators. In South Africa, we have 41 million people who are aged 15 and older. 20% of South Africans in this age group smoke tobacco, which translates into approximately 8 million smokers countrywide. The prevalence of daily or occasional smoking generally increases with age. It's highest at 11% among women in the 45 to 54-year age group. And among men, it peaks at 45% in the 45 to 54-year age group. If we use a conservative estimate and say that, say, 1% of these 8 million smokers were to contract COVID, then we would have 80,000 smokers that would be infected countrywide. And of these infected COVID smokers, of the smokers who would be infected with COVID, if an estimated 5% of those required admission to ICU and then ventilators, this would translate to about 4,000 people needing ICU hospital beds and ventilators in the whole country. Under current calculations, this does exceed the current availability of ventilators in the country, and it places the health workers at risk. If we were to try a few different scenarios, for example, if 0.5% of all smokers in the country were infected, and then only 5% required ICU admission, this would still result in 2,000 people who would need ICU and ventilators, which is still very, very high in terms of the current availability. Therefore, in summary, the majority of smokers were not able to buy cigarettes during lockdown, and this suggests to us that the ban was efficient in reducing cigarette access and therefore use. Cigarette buyers were in close physical contact with people outside of their homes more often than the non-buyers, which suggests less than optimal social distancing. Given that smokers experience more serious COVID outcomes than the non-smokers, which has been presented earlier, South Africans therefore need to be aware of the serious risks that smoking exposes them to should they contract the virus. Thank you very much.
Right, thank you, Ronelle. I've got a couple of questions that have been raised already.
Sure.
One is that does this mean that the lockdown was successful in reducing, in encouraging people to stop? Did people stop smoking because of the lockdown?
I think we can assume yes, because if they were not able to buy cigarettes, then that means that they would not have been able to smoke. And that was the majority of the participants, the 88% during that lockdown.
It could also be that they had, panic bought and they had piles and piles of cigarettes in their homes. That's possible as well. So they didn't need to actually buy.
That is quite possible. But I guess the lockdown was about 5 weeks. So that would be a lot of time to stockpile cigarettes. Therefore, I would assume that a lot had possibly run out. And perhaps the percentage who did buy bought from others who stockpiled. That is possible. However, we don't have sufficient data for me to tell you that for sure.
Okay, so the other thing is, I'll let you come in, Yusuf. The other thing, Ronelle, that is important is this data is also cited a lot in explaining why illegal trade has increased in South Africa. Is that a reasonable conclusion from your study?
I don't think we can make those conclusions because like I said, we're not sure of the types of cigarettes that were bought. We won't be able to say whether they were illicit cigarettes or whether they were done, in the informal markets, and we're not sure if they were bought from other people who stockpiled.
Okay.
So I don't think we can make that conclusion.
No, Yusuf, you can jump in.
Just on the issue of stockpiling, I think South Africa is a very divided society. So we know that wealthier people will have probably stocked up before the lockdown started. But for the majority of our population, if you look at their cigarette buying habits, they buy cigarettes as loosies, as singles. And for those people to buy cigarettes sufficient to last them to the lockdown is simply not practical. They don't have money to buy food. How are they going to buy cigarettes? So the HSRC survey results, as it applies to the whole population, is that relatively few people stocked on cigarettes, and it indicates that people were not able to buy cigarettes and excess cigarettes.
But then also, Yusuf, can you take it further? Because then there is a strong argument, sentiment that is being made that all of this lockdown and banning of cigarette sales is encouraging the illicit cigarette market. What's your view on that?
My view on that is very simple. We've had a problem with illicit trade for the past decade. In fact, longer. Since the tobacco product control laws were passed, we've had problems with illicit trade. And we need to look at what is driving the illicit trade. And the drivers of the illicit trade are the cigarette manufacturers themselves. So earlier this year, we had FITA, one of the organizations, the cigarette associations, accusing BAT of not paying its taxes, British American Tobacco. That's another major, a rival manufacturer. On the other hand, we had British American Tobacco accusing FITA of supplying the illicit market. So the cigarette companies themselves are complicit in cigarette smuggling. Now, how do we deal with the smuggling issue? We deal with the smuggling issue by enforcement. Just as when people didn't observe the lockdown, we had to get the police and the army to ensure that lockdown regulations were observed. So similarly, we need to enforce. And in the case of illicit trade, the most important problem is this, that when people are arrested with smuggled cigarettes, the fines that the courts impose on people are very low. So the incentive to smuggle is high and the disincentive for smuggling is very low. So smuggling is a problem, but it's best solved by proper enforcement of the law, not by weakening the law.
So can you also comment then, Yusuf, on this issue of the fact that imposing a lockdown on people then imposes on people the need to stop smoking, and they are dealing with issues of addiction and so forth, and it's not fair, because then that's another thing that, you know, we are not able to speak to that in terms of COVID-19 and the evidence that we have. But these are questions that people are asking.
All right, I'll address those. But let me just say that, you know, the lockdown has had a severe impact on our rights and ability and freedoms. So for instance, we've lost the freedom to move. People have lost the freedom to the right to work. We've lost the right to education. We've lost the right to pray in churches, temples, synagogues, and mosques. All of those rights have been curtailed. And I find it fascinating that the only industry that wants to take the government to court is the cigarette industry. So why has cigarettes become such a big issue? And I think there's a hidden agenda that's pushing the cigarette issue forward. Now let's deal with addiction. There's a basic premise, and what is the addiction based on? And there's a basic premise that stopping smoking is a very difficult, impossible thing to do. Now let's give you some facts, and these are facts. The majority of South Africans believe that stopping smoking is not an impossibly hard thing to do. They believe it's hard, but they don't believe it's impossible. So we ask them, is it hard to stop smoking? 80% will say, yes, it's hard to stop smoking. When we ask them, do you think you can stop smoking? Just as many, 81% say, yes, I can stop smoking if I really want to. So addiction makes it difficult to stop, but doesn't make it impossible to stop. And most South Africans find that they can deal with addiction. The withdrawal symptoms are temporary. They last for about a week to 10 days. After they subside, apart from a few withdrawal symptoms which last for longer. Those withdrawal symptoms can last for up to a month and even 2 months, and that's craving and hunger. Those are two things that last for a little bit longer. But let's take this addiction argument a little further. Some people are addicted to gambling. So therefore, are we arguing that the government, in order to prevent these people from having withdrawal symptoms, should allow casinos to operate, should allow horse racing, should allow football matches to go ahead, because these people bet on these events as well. So addiction is not a reason for the government not to regulate cigarettes. And I think the most important point, and the point you've made, is that it worsens the pandemic. If people smoke, they are more likely to have severe, and have COVID-19, they are more likely to have severe symptoms which will overwhelm our health service. And that is a critical consideration. Thank you.
Okay, so there's also this issue about whether there's any benefits to short-term smoking, to stopping smoking short-term. Ronel, can you show that the slide? And I would like you, Yusuf, to comment on that. We are basically going in towards the end of our time, but I just want to capture some of these key questions that people have submitted to us.
Okay, there are immediate benefits to stopping smoking. They literally start within 20 seconds. There we are. They literally start within 20 minutes of stopping smoking. And we find that people's heart rates goes back to normal. People's blood pressure goes back to normal. Within 24 hours, the nicotine starts to leave your system within 4 to 6 hours. Within 8 hours, there is more oxygen in the blood because a poison called carbon monoxide is expelled from the body, excreted from the body. And so the ability of the blood to carry more oxygen is immediately improved. And the benefits continue to accrue over the period of time, so that we know literally within 2 to 3 weeks of stopping smoking, people find it easier to breathe. Now, long-term benefits are that within a year, people's risk of heart disease is halved. But it's not just this evidence from there. If you look at the advice doctors give patients who are going in for surgery, and so the surgery may be a few weeks away, and they advise them to stop smoking because the outcome of the surgery will be much better. And they even say to these people, it is preferable that you stop smoking 4 to 6 weeks before surgery. But even if you stop for 12 hours before surgery, your heart rate and your oxygenation levels will improve. So the evidence that smoking and stopping smoking has immediate benefits is there. The evidence that stopping smoking will not change the outlook for COVID-19 patients is not there. It's supposition. People are assuming that there will be no improvement. But the reality is that stopping smoking has immediate short-term benefits.
Okay, so the last thing that I would like you to comment on is the issue. There's been questions about if a cigarette sales ban is so important, why have other countries not banned smoking, cigarette sales?
Well, again, if you look around the world, there are about 160 countries in the world. Only 84 have taken measures to contain COVID-19. So those countries which feel under immediate threat have taken action. There are 4 countries which have banned cigarette sales. That includes South Africa, our neighbor Botswana, Israel, and India. Those 4 countries have banned cigarette sales completely.
Thank you. Francisco, how are we doing?
Sorry, I couldn't find the unmute button. I think we have probably around 5 minutes to wrap up. Would it be maybe a good idea if each of you makes a final statement?
Can I just come in again? I want to say, some people say the government has banned cigarette sales, so because it's harmful to health. So why doesn't the government ban sugar, which is also harmful to health? And this is a very old argument made by the tobacco industry, that if you regulate tobacco, why don't you regulate sugar? Why don't you regulate butter and anything that's harmful? Now, let me just say, the World Health Organization recommends that people stop smoking. They don't say cut down on smoking, they say stop smoking. Because any level of exposure to tobacco smoke is harmful. Even exposure of non-smokers to other people's tobacco smoke can cause cancer and heart disease in those people. The World Health Organization, on the other hand, recommends cutting down on sugar, not stopping sugar use completely. And in South Africa, we've passed laws to increase the tax on sugar to reduce sugar consumption. So we are worried about encouraging people to reduce consumption. But carbohydrates, of which sugar is one, is an essential part of the diet. whereas cigarettes, when used exactly as the manufacturers recommend, cause illness and death.
So, yeah, let's make final comments. Ronelle?
My final comments would just be that in terms of what the data is showing us from a national survey, we found that the majority were not able to buy, and therefore the ban was effective in reducing the amount of people that were smoking at that point, or the data would suggest that, and therefore also reduce the amount of people that were exposed to secondhand smoke. I think allowing smoking during this time would be creating an environment that would be conducive to more or to less social distancing. And our data also showed us that the people who were able to buy cigarettes and who we assumed smoked during lockdown were those that were practicing less social distancing. Thank you.
What would you advise in the way that we interpret data, given a lot of information that's coming through that we have to basically navigate in mind?
I think we have to be cautious. As you mentioned, you know, the pandemic is progressing so fast, and there isn't time to do longitudinal studies. So therefore, we have to, with the available data that we have, which is largely cross-sectional or conducted over a few weeks at a time, we have to be careful, and we have to adjust for as many factors as we can, and just be really careful when interpreting data.
Yusuf?
I think a benefit of the COVID-19, they say every cloud has a silver lining. And although this is hugely disruptive on our economy, the fact that people could not get cigarettes, that cigarette prices were higher, will have the indirect benefit of reducing the numbers of people who smoke in South Africa. And that will have long-term benefits because the economy, we spend more money on treating people who are sick and on lost productivity because workers can't go to work from sickness caused by smoking than we ever get in taxes for the cigarette companies. So long-term benefit of this is that the health of South Africans who stop smoking will improve, and that will reduce the pressure on our health system. I think the legislation is reasonable, it's fair and legitimate. And so I strongly support, and the organizations I've worked for strongly support the continued ban on the sale of cigarettes.
So, but Yusuf, the issue here is that this conversation hasn't really been about the concern for the people who are smoking. I mean, it's been about them, not with them. And in fact, even about them, it's because they're a byproduct of another debate. I mean, can we be sensitive to the fact that these are people, and many of them, they have struggles, they've got pressures, and there's a lot of psychological, mental, there's a lot of social issues that are very complicated that people have to navigate. How would you respond to that?
I think you're absolutely right. And I think this is one of the reasons the tobacco companies have tried to polarize the debate. Many people want to stop smoking. 70% of South Africans say they would like to stop smoking. And many of them would have used the opportunity created by the lockdown to stop smoking. But the industry has changed it. And I have enormous sympathy. I've worked for 40 years in helping people stop smoking. So I understand the difficulties they face. But the difficulties they face are not insurmountable. They can stop smoking. I've received letters from people who say, you know, I've been trying for 40 years to stop smoking and never succeeded. But with the lockdown and the non-availability of cigarettes, I've now not smoked for 2 weeks. So people have found that they have the resources to stop smoking, that addiction is a handicap, but it's not an insurmountable barrier. So we understand the concerns of people, but the industry has polarized it and made it an issue of freedom. Instead of saying you can take control of your life, you can beat addiction, they've tried to say the government is trying to control your life. And so they've tried to reverse it. But the benefits are, we understand people are addicted, but they can overcome that addiction. And millions of Africans have stopped smoking in the last decade.
Yeah, I mean, Francisco, I would conclude by saying that, you know, we are trying to fight COVID-19, and we're finding ourselves caught up in the middle of a war that's been raging for such a long time. And it's become quite difficult for us to move forward when we are trying to deal with a pandemic, and yet there's a tug of war that's really derailing the efforts that we're trying to put in place. But it's been very educational for me. And I hope that we can find a way to make sure that these messages will filter. So thank you, colleagues, for joining the panel. Francisco, back to you.
Yeah, thank you very much.
Yeah, I should also thank all the questions. Yeah.
You know, thank you, Mosa. And I'm also, you know, when I started this webinar series, the name is still Data at Breakfast, yeah, and I'm still very happy to hear that all our discussion was centered about the evidence that emerges from a really scientific and thorough analysis of the data that we have available. Yeah? We heard about the surveys of the Human Science Research Council of the World Health Organization, the many scientific papers that Mosa mentioned. So that I think it's very important, and in particular in these times of of crisis and challenges, that the fact that we stick to evidence and science is probably ultimately what will save us from a major from a major crisis down the line. So Mosa, I thank you very much for putting together a very exciting panel. Yeah, thank you very much, Ronel, for joining us. Thank you very much, Yusuf, for joining us, and thank you to the almost 250 participants that joined us from probably from all over the place, because I browsed the names and I know that many people are not in Durban, so they are all over the place. So it seems that we are still addressing interesting questions, and we will try to to do so in the near future as well. So again, thank you very much, Mosa. Thank you very much, Yusuf. Thank you very much, Ronel. Thank you very much to all the participants for joining us this morning. And we will share the link to the YouTube video later, so that people that didn't have the opportunity to watch it live might be able to join it. So thank you very much, and have a great day, and stay safe.